Acromegaly, excessive secretion of growth hormone in adults after fusion of the epiphysis, physiology, hormone, growth hormone, gland, pituitary gland, anterior lobe, function of the hormone for carbohydrates, hyperglycemia, fat, lipolysis, protein, anabolic, bone, muscle, and viscera, minerals. It increases the levels of sodium, potassium, calcium, and phosphate. Regulation of this hormone, it's increased by growth hormone releasing factor, hypoglycemia, sleep, and after arginine infusion. It's decreased by growth hormone release inhibiting factor, hyperglycemia, stress, and exercise. Etiology for the acromegaly, pituitary adenoma, it may secrete growth hormone only or co-secrete growth hormone with prolactin, rarely carcinoma. B. Paraneoplastic syndrome, bronchogenic carcinoma, multiple endocrine neoplasia, type 1, MEN1, tumors in pituitary, parathyroid, and pancreas, excessive growth hormone releasing factor in hypothalamic hamartoma. Then we have clinical picture of the cause, pressure manifestations of pituitary adenoma, visual field defect, homonymous hemianopia, clinical picture of the hormone for carbohydrates, diabetes in 25% of the cases, fat, excess lipolysis, loss of subcutaneous fat, wrinkling of the skin. Proteins, we have excess growth of bones, muscles, and viscera, bones, skull, periosteal new bone formation of the skull and mandible resulting in frontal busing, maxillary overgrowth, nasal broadening, deepening of creases on the forehead and nasolabial folds, prominent supraorbital ridges and mastoid processes, prognathism, prominent lower jaw with separated teeth, hypertrophy of the larynx and tongue, macroglossia, hollow deep voice, and sleep apnea. These changes result in coarsening of facial features that are noticed when old patient pictures are seen. Hands and feet, spade hands, enlargement of the feet, frequent change in rings and shoe size, hypertrophy of joint, cartilage, and osseous overgrowth, resulting in carpal tunnel syndrome and osteoarthritis. Visceromegaly, hepatosplenomegaly, cardiomegaly, congestive heart failure, cardiomyopathy, the most common cause of death in acromegaly, colonic polyps and increased risk of colonic cancer, endothelial hyperplasia, hypertension, hypertrophy of skin, sweat, and sebaceous glands resulting in moist, greasy skin and skin tags. Muscle power is increased early in the disease but decreased late due to hyperkalemia, minerals, hypertension from hypernatremia, and muscle weakness with arrhythmia due to hyperkalemia, neurological manifestations, depression, carpal tunnel syndrome, peripheral neuropathy, spinal cord compression, proximal myopathy, and pressure manifestations of tumor in the skull. Causes of carpal tunnel syndrome in general, diabetes, rheumatoid arthritis, acromegaly, myxedema, and musicians. Associated endocrinal manifestations, diabetes in 25% of the cases, growth hormone is anti-insulin hormone, hyperprolactinemia due to co-secretions from acidophils, 25% of pituitary adenomas, or pituitary stalk compression, decreasing hypothalamic prolactin release inhibitory factor, PIF, deficiency of other anterior pituitary hormones due to compression of the anterior pituitary, hypogonadism if associated with hyperprolactinemia or decreased pituitary gonadotropins, rarely diabetes insipidus due to compression of the posterior pituitary. Investigations for the cause, imaging for the gland, CT and MRI, assay for the hormone level, fasting growth hormone, it's elevated but it's not useful for diagnosis, increased insulin growth factor 1, somatomedine, hyperprolactinemia, and suppression of other anterior pituitary hormones may occur. Growth hormone is difficult to measure because of its pulsatile secretion, so insulin growth factor 1 produced by the liver in response to growth hormone is measured instead. Investigations of the function of the hormone, increased glucose, sodium, potassium, calcium, and phosphorus, X-ray, skull, sick cortex, widening of the sella turcica and nasal sinuses, prominent supraorbital ridges and occipital protuberance, prognathism with wide separation of teeth, hand, tufting of the terminal phalanges, mushroom shape, suppression test, oral glucose tolerance test. Normally, when it's positive, it decreases the level of growth hormone, but in acromegaly, negative or no suppression. After overnight fasting, 50 to 100 gram of oral glucose causes suppression of growth hormone over the subsequent 30 to 90 minutes to less than 2 nanogram per milliliter in normal persons, but it remains above 2 nanograms per milliliter in acromegalic patients. Others, echocardiography and colonoscopy, should be performed to evaluate the cardiomegaly and colon polyps. Treatment, surgery, hypophysiectomy, transsphenoidal, the preferred initial treatment, Radiotherapy, second choice if growth hormone is still elevated after surgery or if complete excision of the tumor is not possible, or in a case of recurrence. Medical treatment, third choice, subcutaneous somatostatin analogs, octreotide, lanreotide, pathreotide, newer somatostatin analogs, growth hormone receptor antagonist, pegvisomant, dopamine agonist, less effective than octreotide, large doses needed with increased incidence of the side effects, and finally symptomatic treatment for diabetes mellitus and hypertension. Gigantism definition, increased growth hormone secretion before fusion of epiphyses. Clinical picture, generalized overgrowth of skeleton and soft tissue. Disproportionate gigantism, span is more than height. Later on, features of acromegaly develops. Lastly, decline stage usually occurs due to pituitary hypofunction. Differential diagnosis for tall stature, familial and racial, the commonest. Number 2, gigantism. Number 3, excess androgen, tall children, short adults. Primary hypogonadism, disproportionate gigantism with feminine characters, and finally Marfan and Klinefelter syndromes. Parathyroid gland, calcium metabolism, normal calcium level from 8.4 to 10.2 milligram percentage, ionized or active 50 percentage, non-ionized or reserve 50 percentage, 40 percentage bound to albumin and 10 percentage in any other bound, calcium carbonate and phosphate. Liver cirrhosis and nephrotic syndrome decreases albumin, leading to hypocalcemia but no tetany because ionized calcium is still normal. Regulation of calcium is closely affected and related to phosphorus, normal level from 3 to 4.5 milligram percentage. Notice that calcium times phosphorus equal constant, which is 40. Serum calcium and phosphorus levels are controlled by certain hormones, parathormone, calcitonin, and active vitamin D. Calcium regulation involves 3 sites: bone, intestine, and kidney. Parathormone, it increases calcium absorption in intestine, reabsorption from the kidney, resorption in bones, and the net result is increased calcium in the blood. It decreases phosphorus absorption, reabsorption, and resorption, decreasing the whole phosphorus in the blood. Vitamin D, it increases calcium as well as parathormone, but it also increases phosphorus, while calcitonin, it decreases calcium and decreases phosphorus. Parathormone acts directly on bone, kidney, and indirectly on intestines through the activation of vitamin D. Hyperparathyroidism, physiology, hormone, parathormone hormone, polypeptide containing 84 amino acids, gland, parathyroid gland. Function of the hormone, increases calcium level and decreases phosphorus. On GIT, it increases absorption of calcium indirectly through vitamin D. It increases the formation of biologically active 1,25-dihydroxyvitamin D from inactive form 25-hydroxide vitamin D by stimulation of renal 1A hydroxylase enzyme and inhibition of 24-hydroxylase enzyme, which metabolizes the active form into the inactive form. Kidney, it increases reabsorption of calcium. Bone, it increases resorption of calcium, and it also increases the renal phosphate excretion. Regulation of this hormone, stimulators are hypocalcemia, hyperphosphatemia, and adrenaline. Inhibitors are hypercalcemia, calcitriol, vitamin D3, hypophosphatemia, and severe hypomagnesemia, which produces symptoms of hypoparathyroidism. Etiology, primary adenoma of the parathyroid gland, most common 80%, hyperplasia of the parathyroid gland, and finally part of the men multiple endocrine neoplasia, MEN1 or MEN2A. MEN1, hyperparathyroidism, 95%, pituitary tumors, 30%, and pancreatic tumors, 70%. MEN2A, medullary carcinoma of the thyroid, 90%, Pheochromocytoma, 40%, and finally hyperparathyroidism, 25%. Secondary, due to decreased calcium as in chronic renal failure or malabsorption syndrome. Tertiary, hyperparathyroidism, usually in end-stage chronic renal failure. Long-standing secondary hyperparathyroidism leads to irreversible parathyroid hyperplasia. It starts secondary, then ends tertiary. Parathyroidectomy is the only appropriate treatment. And finally, paramalignant syndrome, oat cell carcinoma. Clinical picture, 50% are asymptomatic, more common in females more than 50 years. Disease of bone, renal stone, abdominal groans and psychic moans. Bone, osteitis fibrosa cystica. Pain, pathological fracture, osteitis fibrosa cystica. Fibrous degeneration and cysts formation due to osteoclastic activity secondary to hyperparathyroidism. Renal, repeated stones, polyuria, calcium diabetes, and polydipsia, nephrocalcinosis and renal failure. Others, CNS, drowsiness and depression, GIT, constipation, peptic ulcer, pancreatitis, abdominal pain, CVS, ECG, short QT interval, arrhythmia, hypertension, skin dry and itching. If calcium level is more than 11 milligram percentage, we have clinical manifestations of calcium. If it's more than 13 milligram percentage, we have renal impairment. And if it's more than 14 milligram percentage, we have coma and cardiac arrest, endocrinal emergency. The differential diagnosis of hypercalcemia, primary hyperparathyroidism, and malignancy are the most common causes and account for more than 90% of patients with hypercalcemia. Endocrine, we have hyperparathyroidism, primary and tertiary, the most common cause, hyperthyroidism, Addison's disease, acromegaly, Pheochromocytoma. Malignancy, bronchogenic carcinoma, multiple myeloma, lymphoma, because it activates vitamin D. Bone, TB, sarcoidosis, immobilization. Others, hypervitaminosis, vitamin D, drug-induced cyanide and lithium. Familial, hypocalciuric hypercalcemia. Investigations, we have investigations for the cause, parathyroid imaging, CT, MRI, radioisotope scan, assay for the hormone level, parathormone, it's elevated, the normal is from 0.5 to 1 nanogram per milliliters. Investigations of the function of the hormone. For blood, in primary hyperparathyroidism, we have elevated calcium, reduced phosphorus, and elevated alkaline phosphatase. In secondary, we have reduced calcium, elevated phosphorus, and elevated alkaline phosphatase, while in tertiary, everything is elevated, calcium, phosphorus, and alkaline phosphatase. Persistent hypercalcemia with hypophosphatemia and elevated parathormone confirms the diagnosis of primary hyperparathyroidism. Urine, increased calcium, increased phosphorus, and increased hydroxyproline with cyclic AMP due to increased bone resorption. X-ray for bones, loss of lamina dura of the teeth, earliest sign, subperiosteal bone resorption in the distal phalanges and distal end of clavicle, ground glass appearance, osteopenia, skull, mottling of the skull, salt and pepper skull, spine, codfish appearance, indentation of vertebrae by discs, renal, urinary stones and nephrocalcinosis, bone biopsy, osteomalacia with excess osteoclasts, suppression test, steroid test, positive, decreased calcium level, normal, negative, no suppression in hyperparathyroidism. Treatment, surgery, removal of the parathyroid glands with calcium and vitamin D supply. Indications for surgery, age less than 50 years, serum calcium more than 1 milligram percentage above the upper limit of the normal, creatinine clearance less than 60 milliliter per minute, BMD T-score less than negative 2.5 at any site, and or previous fracture fragility. Medical treatment of hypercalcemia, decreased intake, increased fluid intake, decreased absorption by oral phosphate, increasing loss of calcium, salines and furosemide or dialysis in severe cases, calcitonin, beta blockers to decrease the adverse effects of the hypercalcemia on heart. Cortisone is effective in some cases related to vitamin D excess, and finally alendronate or Osteomax decreasing osteoclastic activity. Hyperglycemic crisis, serum calcium levels more than 14 milligram percentage, manifestations non-specific, confusion, coma, polyuria, dehydration, arrhythmia, shortened QT interval, nausea, vomiting, constipation, and abdominal pain. Treatment, IV normal saline 4 to 6 liters per day may be necessary, the first goal. Then we give Lasix 40 to 80 milligram IV every 2 hours, and it should never be administered without saline infusion because this will lead to dehydration aggravation. IV Pamidronate or Aridia, drug of choice. It inhibits osteoclastic activity. The dosage from 30 to 90 milligram IV infusion over 24 hours. Calcitonin inhibits bone resorption and have a hypercalciuric effect. Cortisone, the first line of treatment for hypercalcemia caused by vitamin D excess, such as myeloma, lymphoma, sarcoidosis, but not beneficial in hyperparathyroidism. Dialysis, effective in removing calcium in patients with renal failure. Cushing syndrome, physiology, hormone, increased cortisol level, glucocorticoids, gland, suprarenal gland, zona fasciculata, functions of the hormone, hyperglycemia for carbohydrates, insulin resistance, proteins, catabolic, fat, lipolytic, and redistribution of fat in abnormal sites, face, back of the neck and trunk, water and electrolytes, aldosterone-like, increasing salt and water retention and decreasing potassium with hydrogen ions, stomach, increasing HCl, bone, anti-vitamin D action, blood, increasing RBCs and neutrophils, decreasing lymphocytes, eosinophils and basophils, psychosis, androgenic effect, anti-inflammatory and anti-allergic, regulation of the hormone stimulated by ACTH. Etiology: it's divided into two types, ACTH-dependent and ACTH-independent. ACTH-dependent is subdivided into pituitary adenoma and paramalignant syndrome. Pituitary adenoma, pituitary Cushing or Cushing disease or secondary Cushing, basophil adenoma of the pituitary gland secreting ACTH. Paramalignant syndrome, oat cell carcinoma, ectopic ACTH producing tumors. ACTH independent, undetected ACTH with elevated cortisol more than 15 mcg per deciliter. Adrenal adenoma, primary Cushing or Cushing syndrome, exogenous administration of excess steroids, Cushingioid picture, this is the most common. Clinical picture of the cause with the pituitary tumor, paraneoplastic syndrome. Clinical picture of the hormone. Carbohydrates, we have glucose intolerance and maybe secondary diabetes in 15%, protein, catabolic, muscle wasting and weakness, capillary fragility, purpura, osteoporosis, thinning of the skin, fragile skin which tears and bruises easily, stria rubra, delayed wound healing, fat, abnormal deposition of fat, moon face with acne, interscapular area, buffalo hump, and I'm sorry for using buffalo word, truncal obesity with thin limbs, sambuca-shaped obesity, water and electrolytes, increased sodium and water, decreasing potassium and hydrogen ions, hypertension due to increased sodium and increased action of catecholamines, manifestations of hypokalemia, alkalosis, stomach, peptic ulcer, perforation, bone, osteomalacia, osteoporosis, blood, polythysemia, plethoric phase, recurrent infections due to diminished function of neutrophils, psychiatric, depression and suicidal tendency, androgenic action, females, amenorrhea, hirsutism, male, decreased libido, impotence and hirsutism, skin pigmentation only in secondary ACTH-dependent Cushing due to increased ACTH. Cause of death, cardiovascular disease and infection. Features suggesting ectopic ACTH secretion, paraneoplastic syndrome, short duration, severe hypokalemia, severe hyperglycemia, and finally, which is the most important one, weight loss rather than weight gain. Differential diagnosis for the cause, primary or secondary Cushing, pseudo-Cushing syndrome, chronic alcoholism impairing liver function and impairing metabolism of corticosteroids, obese, hypertensive, diabetic patients, females taking OCPs, and finally depression and stress. In pseudo-Cushing, increased urinary steroids but without diurnal variation of steroids. Investigations. We need to check out if it's Cushing and after checking out, we need to differentiate between pituitary, adrenal, and ectopic causes. Is it Cushing? Any suspected case of Cushing should be subjected to 3 tests: 24 hours urine-free cortisol, late-night salivary cortisol, and low-dose dexamethasone suppression test. 24 hours urine-free cortisol, the normal is less than 100 microgram per day, high in Cushing syndrome 3 to 4 folds, depression and obesity. This is the single best biochemical marker of Cushing syndrome. Low-dose dexamethasone suppression test, 1 mg overnight of oral dexamethasone test at 11 p.m. Normal response, morning suppression of cortisol level to be less than 5 microgram percentage. No suppression, plasma cortisol more than 5 microgram percentage, suspect Cushing. Then we have to differentiate between pituitary, adrenal, and ectopic causes. Morning ACTH level, high-dose dexamethasone test, and BIPS. Morning ACTH level at 9 a.m. It's elevated in pituitary, Cushing, or ectopic paramalignant ACTH dependent. MRI of pituitary or CT of the chest to look for ectopic focus. Reduced in adrenal Cushing, adrenal gland CT confirms the lesion. High dose dexamethasone, 0.5 mg per 6 hours for 2 days or 8 mg once at midnight. Positive, decreases cortisol level by more than 50% of the baseline, occurs in pituitary Cushing, while it's negative, no suppression occurs in primary Cushing or ectopic ACTH secretion. Bilateral inferior petrosal venous sampling of the ACTH, BIPS, BIPSS. Each inferior petrosal sinus drains the cavernous sinus into the internal jugular vein. Bilateral inferior petrosal sinus sampling, invasive procedure in which ACTH levels are sampled from the veins that drain the pituitary gland. This test has been the gold standard for differentiating between Cushing's disease and ectopic ACTH-dependent Cushing. If ACTH ratio is more than 2, then this means Cushing disease or pituitary Cushing or secondary Cushing. Investigations of the function of cortisone, biochemical changes, reduced potassium, increased sodium and glucose, blood picture, increased RBCs, neutrophils, and decreased lymphocytes, basophils, and eosinophils. Treatment, surgery, surgical resection of the pituitary, adrenal, or ectopic ACTH-producing tumor, followed by replacement therapy. bilateral adrenectomy if the cause cannot be located. Nelson syndrome, bilateral adrenectomy in 50% of the cases leads to increased ACTH levels, pituitary adenoma, and hyperpigmentation. Irradiation, less effective than surgery, reserved for high surgical risk patients. Medical, steroid antagonist. We have 5 anti-ACTH sodium valproate in pituitary Cushing, ketoconazole antifungal, also anti-glucocorticoid effect. Metyrapone, it blocks cortisol synthesis by inhibiting steroid 11 beta hydroxylase enzyme. Mitotane, antineoplastic, used in treatment of adrenocortical carcinoma, inhibiting adrenal mitochondria. And finally, aminoglutathione, anti-steroid drug. Then we have adrenogenital syndrome, congenital adrenal hyperplasia. Physiology, hormone, sex hormone, androgen, gland, suprarenal gland, zona reticularis, function of the hormone, gametogenesis and secondary sexual characters, regulation of the hormone by ACTH. Etiology, enzyme deficiency in the cortical synthetic pathway. 21-hydroxylase enzyme leads to reducing cortisol level, increasing ACTH, acting on zona reticularis, increasing sex hormone secretion. Clinical picture, it depends on the age and sex of the patient. Prenatal, female pseudo-hermaphroditism, small vagina, big fused labia majora simulating the scrotum. Postnatal and before puberty in males, pseudo-precocious puberty, masculinization, deepening of the voice with small testes and no spermatogenesis. In females, we have virilism, amenorrhea, masculinization, and hirsutism. Hirsutism before menarche is suggestive of congenital adrenal hyperplasia. After puberty, there is virilism in females. Investigations for the cause, imaging of the gland, assay of hormones level. In blood, increased testosterone and ACTH. In urine, increased metabolite of testosterone, 17-hydrotestosterone. Treatment, cortisone, it suppresses ACTH and decreases androgens. Chronic adrenal failure, Addison's disease or adrenal insufficiency. Failure of adrenal cortex leads to decrease in its hormones, primary, secondary, tertiary. Tertiary, hypothalamic, secondary, pituitary, panhypopituitarism, and primary Addison's disease. Etiology of primary adrenal failure, idiopathic atrophy, most probably autoimmune, the most common cause, 80% of the cases. Tuberculosis, 15%. Surgery, irradiation, sarcoidosis, hemochromatosis, adrenal hemorrhage, and meningococcal septicemia. Clinical picture, gradual non-specific symptoms can lead to incorrect initial diagnosis. Clinical picture of the cause associated with other autoimmune diseases, type 1 diabetes, thyroid disease, and vitiligo, polyglandular autoimmune syndrome. Clinical picture of the hormone, hypoglycemia and hypotension. Hypoglycemia due to decreased cortisone, drowsiness, lack of concentration, hunger, pain, coma, but there is absent usual warning signs due to lack of adrenaline. Due to decreased cortisone, there is decreased action of catecholamines. Hypotension due to decreased cortisone and aldosterone leads to decreased sodium, hypovolemia, and decreased response of the blood vessels to the action of catecholamines, leading to hypotension. Postural hypotension is common due to decreased action of catecholamines. Hyperpigmentation due to high level of ACTH in primary adrenal failure. Increased ACTH direct action on melanocytes is not present in secondary adrenal failure. Site, sun-exposed areas, face and neck, friction pressure areas, elbow, pigmented areas, areola, recent scars and nails, mucous membrane, mouth and tongue, GIT manifestations, anorexia, nausea and vomiting, alternating diarrhea and constipation, abdominal pain due to decreased sodium, tender renal angle due to TB, athenia, marked muscle weakness, fatigue, and weight loss in 100% of the cases. Early, it may be sporadic, usually most evident at times of stress. Decreased cortisol, hypoglycemia, decreased aldosterone, hyperkalemia, hyponatremia, decreased androgens, negative nitrogen balance. Others, polyuria due to sodium diuresis, neuropathy, deficiency of adrenal androgen manifesting in females only, leading to loss of axillary and pubic hair because both are under the influence of adrenal androgen only in females. Complications, Addisonian crisis that we're going to explain later. Differential diagnosis, secondary adrenal insufficiency and skin pigmentation. Secondary adrenal insufficiency, hypopituitarism, decreased ACTH, decreased cortisone and androgen with no decreased aldosterone. So in secondary adrenal failure, there is no skin pigmentation, minimal hypotension due to normal aldosterone, and manifestations of panhypopituitarism. Skin pigmentation differential diagnosis, malignancy, pregnancy, hemochromatosis, primary biliary cirrhosis, chronic renal failure, skin diseases, endocrinal diseases, primary Addison, secondary Cushing, diabetes, and thyrotoxicosis. Investigations, low cortisol level less than 5 microgram per deciliter, confirmed by ACTH stimulation test. Investigations for the cause, imaging for suprarenal gland, abdominal ultrasound, CT, MRI, adrenal antibodies in autoimmune cases. Chest X-ray may show evidence of old or active TB, and investigations for thyroid and diabetes in suspecting polyglandular autoimmune syndrome. Assay of hormonal level. Low morning cortisol level less than 5 microgram per deciliter is highly suggestive. If it's more than 18 microgram per deciliter, it should rule out adrenal insufficiency. ACTH level elevated more than or equal to 50 pg per milliliter in primary adrenal failure and decreased in secondary adrenal failure. Aldosterone is deficient in primary adrenal insufficiency and not deficient in secondary adrenal failure because it's under control of renin, not ACTH. Investigations of the functions, biochemical changes in blood picture. Blood picture reduced neutrophils and increased lymphocytes, eosinophils, and basophils. There is a reverse in Cushing syndrome. Biochemical changes, serum sodium decreased less than 135 milliequivalent per liter. Serum potassium increased more than 5. Fasting glucose less than 50 milligram per deciliter. Bicarbonate less than 15 milliequivalent per liter. Metabolic acidosis and BUN exceeding 20 milligram per deciliter due to pre-renal azotemia secondary to hypovolemia. The distinction between primary and secondary adrenal failure is usually clear. Stimulating test, ACTH stimulation test, synthetine or synthetine, synthetic ACTH, 250 mcg IV or IM, followed by measurement of serum cortisol levels 0-30-60 minutes. Normal response positive, increased cortisol level more than 18 microgram per deciliter. Primary adrenal failure, negative response, it never exceeds 18 microgram per deciliter. Treatment of the cause, TB, diet, increased sodium, carbohydrates, protein. Replacement therapy, we have glucocorticoid replacement and mineralocorticoid replacement. Glucocorticoid replacement, HAB, hydrocortisone, prednisolone, dexamethasone. Hydrocortisone 20 mg AM, 10 mg PM, or prednisolone 5 mg AM, 2.5 PM. Dexamethasone 0.5 AM, 0.25 PM. Mineralocorticoid replacement, fludrocortisone 0.1 mg per deciliter, per day, to replace aldosterone, especially in severe hypotension. During stress, infection, or surgery, intercurrent infections, the dose of hydrocortisone is doubled. Surgery, pre-medication was 100 mg of cortisone intramuscular, hydrocortisone intramuscular, then 100 mg per 6 hours intramuscular for 1 day before minor surgeries and for 3 days for major surgeries. Then we have acute adrenal failure or adrenal crisis, medical emergency, fatal if not recognized and treated immediately. Etiology, acute on top of chronic and acute from the start. Acute on top of chronic, Addison's disease subjected to stress, surgery, infection, bleeding. Panhypopituitarism, if treatment is initiated with thyroxine. Acute from the start, surgery, bilateral adrenalectomy, sudden withdrawal of chronic cortisone therapy. Meningococcal septicemia, Fredrickson's syndrome, massive thrombosis of adrenal vein. Clinical picture of the cause, surgery, infection. Clinical picture of hormone, severe hypoglycemia, coma. Severe hypotension, shock, should be considered in any case of unexplained shock. Severe athenia, confusion. Severe skin pigmentation, desquamation. Severe diarrhea, dehydration, and acute abdomen. Investigations such as Addison. Acute adrenal failure should be suspected in refractory hypotension or unclear etiology of hypotension. Refractory hypotension means that it doesn't respond to vasopressors or IV fluid support. Treatment, SSS, not of Asralaini, steroid, sugar, saline, IV fluids, 1 to 2 liters of normal saline, 0.9% NaCl, and 1 to 2 liters of 10% glucose. Cortisone started immediately as follows. Hydrocortisone, 100 mg per 6 hours IV until the patient is clinically stable. Then shift to oral cortisone. Dexamethasone can be given before or during ACTH stimulation test. It will not interfere with plasma cortisol assay. Fludrocortisone not needed during adrenal crisis because glucocorticoids in high dose have mineralocorticoid effect. Treatment of the precipitating factors such as infection or DIC, Pheochromocytoma, hyperfunction of adrenal medulla, commonest tumor arising from the adrenal medulla, rule of 10. 10% familial, 10% bilateral, 10% malignant, and 10% extra-adrenal in the sympathetic chain. Clinical picture, paroxysmal hypertension, headache, swelling, tachycardia, anxiety, and psychiatric disturbance. Investigations, urinary catecholamines elevated plasma catecholamines, CT scan MRI for abdomen, elevated urinary VMA, valine mandelic acid, and finally radioisotope scanning with MIPG, Me2 iodobenzyl produces specific uptake in sites of sympathetic activity. Treatment: surgery is a treatment of choice. Medical: combined alpha and beta blockers. Don't start with beta blockers because this will lead to unopposed alpha action leading to hypertensive crisis. And this concludes our part for today.